So we are at the fag end of the session, and we are going to discuss a very important topic from patient's point of view, that is the pain management in GI cancers. All of us know that GI malignancies are the malignancies with massive pain. They can cause horrendous kind of pain, especially pancreatic malignancies, hepatobiliary malignancies, and CA stomach. We are going to have 3 deliberations in this session. One is endoscopic management, second is pharmacological management, and last one is psychotherapy and counseling, which is equally important. So to begin with, I will invite Dr. Lalit Nihal from Raipur, who is a endoscopic gastroenterologist, to talk about the endoscopic intervention. If I am right, Dr. Lalit?
Thank you. Thank you so much. Good evening. At the outset, I would like to thank Dr. Sanjay Kumar for the invitation, and it's an honor that my teacher, Dr. Mishra, is chairing this session. So, the pain that we have in the back for sitting for such a long time, and the pain of waiting for the painkiller after the session is very inferior to what a cancer patient goes through. So, a cancer patient, the pain reminds him about the disease and death. So, we need to tackle it. So, a dream medication for pain would be which relieves the pain and doesn't cause any side effects. The visible physical pain is only the tip of the iceberg. The effect of the pain on psychology, on social aspect is equally important. So the WHO pain ladder came in existence in 1986. But do we need a 4th step in this to include the interventions? Now, after 35 years, they have included the 4th step, where the invasive methods of treating the pain are included, and this is a bidirectional approach. So you can go up the ladder, and when the pain is relieved after the session, you can come down the ladder as well. So what are the indications of doing an invasive procedure in patients with cancer pain, which is a pain which is not relieved by strong opioids or has unacceptable side effects, a patient who is in pain crisis, a patient's desire to avoid systemic therapy or short life expectancy, but for a patient, that may be the only life that he has. There are so many sympathetic ganglia that can be targeted for pain, but we will be focusing on celiac plexus for upper GI cancers. As we know, the celiac plexus innervates all the upper abdominal viscera, omentum, and peritoneum. And we need to understand that when we block the celiac plexus, the pain from these organs is not transmitted to the pain sensitive areas. It was first described almost 100 years ago by Capes when he injected steroids in the celiac plexus of a patient with chronic pancreatitis. We combine nowadays with bupivacaine to induce longer pain relief. But in cancer patients, we need to do a neurolysis, because in these patients, we want a permanent treatment. We use alcohol and phenol. Nowadays, most of the times we are using 95% to 100% alcohol, because it gives longer duration of relief, and as compared to the daily dosage of drugs, it is much cheaper. Frequent visits to the hospital are not required. Patient can remain at home and pain-free. But it needs a skilled practitioner and endoscopic ultrasound and imaging equipments. If you look at the various blocks that are used, celiac plexus block is very low risk and very high benefit. So indications are severe upper abdominal pain, pain score more than 7, poor control on NSAIDs and opioids, life expectancy more than 3 months. But we will not do this if the patient has pain in multiple areas apart from the abdominal pain, and if he has a coagulopathy. So this was an Indian study from TMH which proved that celiac plexus neurolysis is a better alternative for pain management in these patients. There are so many modalities available now. We can do it ultrasound guided, CT guided, transdiscal, we can do it thoracoscopic or laparoscopically, but the best approach today, the best evidence we have is endoscopic ultrasound guided approach. So we use a linear echoendoscope which gives us the best vision parallel to the scope, and we can put the neurolytic agents under vision in real time. And you can see these beautiful images of the celiac plexus and the needle going inside the plexus directly. What are the predictors of pain response? An invisible ganglia, a distant metastasis, or celiac plexus invasion, these are the negative variables. The strongest predictor of response in patients who have a body or tail tumor, they have the best response as compared to people who have a head tumor. So can we jump the WHO ladder? And that's why I think Dr. Sanjay Kumar put the endoscopic talk as the first, because now what we are doing is, if the patient has significant pain, neurolysis can be offered as the first line therapy, because once they develop the somatic component of the pain, then it becomes difficult to treat them. So not only we do neurolysis nowadays, we can use, today we saw a beautiful demonstration of RFA, we can use RFA in these patients to ablate the plexus, and at the same time in palliative care of pancreatic cancer, nowadays RFA can be used for ablating the tumor as well. So what are the advantages of doing it under endoscopic ultrasound guidance? It has a very low complication rate because of the anterior approach, avoids the neural structures of the back. Because of the short distance, it is very efficacious, and it is preferred because it has very minimal side effects like transient hypertension or transient diarrhea after the procedure. So now we have a meta-analysis of almost 24 studies on the US, and a Cochrane review also has come which shows that pain relief is achieved in almost 90% of patients at 2 weeks and almost 70% till death. Significantly lower opioids are used in these patients, and that reduces the side effects of opioids. And not only it improves the quality of life, it has been shown to improve the quantity as well, the longevity. So endoscopic ultrasound is a one-stop shop in patients with pancreatic cancer for diagnosis, for staging, for doing FNA biopsies, for doing the biliary drainage, celiac plexus neurolysis, and finally the tumor ablation. So once the patient comes to the endoscopy table, you can offer an all-round palliation on the table. This is the biggest advantage of doing the procedure under endoscopic ultrasound guidance. But it remains a team approach, and my speakers coming after me will tell you what they do. I will take this opportunity to invite all of you to join us in Raipur on 18th or 19th of May for the GI medicine update. Thank you very much.
Thank you, Dr. Nihal. I think you can take a seat over here and be us for the rest of the session. Now we invite Dr. Anupam Pathak for the second talk. He specializes in pain management and is a senior consultant at GastroCare Hospital.
Hello everyone, I won't take much of time. This is something I would like to remind you of. Pain is temporary, glory is forever. You all know, let us take a bit of pain to learn what pain is all about. I don't know how many of you will be having pain or some amount of sadness seeing this. This can be attributed as acute pain. This is Dhoni getting run out in 2019 World Cup. This is chronic pain. So it's the duration of the disease that we can define pain as acute or chronic pain. Now the pain. Pain is something an unpleasant sensory and emotional experience that is attributable to potential or tissue damage. Now the pain is the only symptom in cancer which reminds the patient of the disease every minute and also reminds of death every second. Current population of India is around 1.38. I think it is more than this. Cancer incidence is around 1.7 million. Cancer deaths are attributed about 0.8 million per year, and 2/3 of them present in advanced stage. But 96% of adults and 99% of children, there is no excess of opioids. Reality, 90% of pain can be managed, but they still suffer pain. There are guidelines present which Dr. Nihal has said, but many of we don't utilize these guidelines. What does pain mean to patients? Pain usually reminds patient of poor prognosis or impending death, particularly when pain worsens. It's impaired physical and social function, decreased enjoyment and quality of life, and challenges to dignity. This slide has already been shared by Dr. Nihal, and GS Tober is one patient that quote, one of the worst aspects of cancer pain is that it's a constant reminder of the disease and of death. GS Tober herself died of cancer, but she made guidelines on pain management. Now the prevalence of pain. Why cancer is more painful compared to normal tissue injury? Because of the cancer cells induce macrophages and inflammatory cells that produces high levels of COX-2 enzymes, high levels of prostaglandins, and this massive apoptosis also contribute to release of H+ ions and increase acidosis. This is pain prevalence. Now the cancer pain etiology, it can be attributed directly to tumor infiltration of tissue. Diagnostic and therapeutic procedures, especially the chemotherapy, radiotherapy, they all causes a much of pain. This diagnostic test also causes a lot of pain to the patients, which we don't take care of, frankly. Malignant infection, inflammation, concomitant existence of deep conditions such as diabetic polyneuropathy, headaches, osteoarthritis. Now the tumor-related pains are 60 to 80%, therapy-induced, chemotherapy-induced peripheral neuropathy that can be treated, but we don't usually treat it due to tumor, and this is due to chemotherapy-induced pain. This is related to radiation therapy, and these are totally unrelated. You can get herpes and all, mucositis. Breakthrough pain. Now the transient flare of pain of moderate to severe intensity on a background of controlled pain. It will be rapid onset, moderate to severe intensity, short duration of usually it ranges between 30 minutes, and poor functional outcome, negative social and psychological outcome. Usually they don't respond to opioids. If we cannot assess pain, we will never be able to relieve pain. Some quick points on the general history. Medical history is an important part of the pain. A comprehensive assessment of any chronic complex pain conditions require documenting pain history, physical examination, specific diagnostic tests. There is an acronymic: onset, precipitation, quality of pain, radiation, severity, and timing of pain. And that we can remember it by OPQRST. Diagnosis by pain intensity, mechanism, somatic, visceral, neuropathic. Neuropathic usually respond to pre-gaps and all. Etiology, cancer, non-cancer. We should always rate pain on pain scales. Otherwise, we have to, when we give these medications, then we will be better able to assess whether we are able to justify our treatments. Pain scale, there are pain scale on a range of 0 to 10. There are multidimensional tools such as McGill pain questionnaires, brief pain inventory, McGill pain scale, Wong-Baker pain scale. This is these scales are used for kids. In this, we use face, legs, activity, cry, consolability. Now the management strategies. Yes, we offer so many treatments, but I don't think they cater to the need of the patients. This slides had already been shared by Dr. Nihal. It should be a comprehensive team management approach. Non-pharmacological methods include acupuncture, biofeedback, distraction, hypnosis, these all. Now there is a WHO analgesic ladder. It's a 5-point recommendation that includes oral administration of analgesics. Analgesics should be given at regular intervals. They should be prescribed according to pain intensity as evaluated by a scale of intensity of pain. Dosing of pain medication should be adapted to the individual. Analgesics should be prescribed with a constant concern for detail. These are the 3-step ladder. They have 5 essential concepts: by mouth, by the clock, by the ladder, by individual, with attention to detail. In step 1, we usually use non-opioid plus adjuvant. And for mild to moderate pain, we can use opioid, mild to non-opioid and adjuvant. And on a step 3, opioid for moderate to severe pain plus non-opioid plus adjuvant. They have included a fourth step as the intervention, which Dr. Nihal has already explained. This is a modified 4-step approach, and we use step-up therapy for chronic cancer pain and step-down therapy for intense acute pain. Adaptation of WHO step ladder pattern, in which we use invasive techniques, opioids like transdermal buprenorphine patch, fentanyl patch, adjuvants, step up, step down, pure. This WHO ladder also is for the individual, tailor pain relief to individual needs and circumstances. Step 1 includes acetaminophen and NSAIDs. This is all pharmacological methods. So COX inhibitors, selective COX inhibitors usually don't cause ulcers and all. Now step 2 and step 3, if we are using opioids, we aren't breaking bad. It's not like that opioid use can cause some problems or some disease. Opioids, we can use step 2, like moderate opioids like tramadol. In step 3, we use morphine, fentanyl. Opioids alter the unpleasant emotional experience associated with pain, provide pain relief throughout the interaction with specific opioid receptors. No ceiling, usually there is no ceiling effect to opioid dose exists. Doses can be escalated to provide analgesia as long as there are no unacceptable toxicities. Ineffectiveness may also reflect progression of the underlying disease. General principles, we all know. Equianalgesia, now this is equianalgesia dose means how much dose is equal to another dose of another opioid. That 10 mg of morphine is equivalent to 250 microgram of fentanyl. If you are changing from one opioid to another opioid. Opioid dose escalation can be done from 25% escalation. This is all pharmacological. Now the opioid side effect, constipation is the only side effect that doesn't show tolerance. All other side effects usually show tolerance. So we can use the proactive laxative use like oral naloxone, methyl naltrexone, albumin. These are mild side effects which can be controlled. Itch, rash, respiratory depression, neurotoxicity, drug and these are. WHO ladder, is it effective? Yes, it is effective. But the limitations of WHO ladder is pain is neuropathic or bony in nature, breakthrough pain, intolerance side effects, non-availability of lack of knowledge. This is pain management. Treatment of pain, we can use for bone mats, we can use strontium, zoledronate and all. What we do? We should follow WHO analgesic ladder. Now the co-analgesic, a word on co-analgesic, which enhance analgesic efficacy, have independent analgesic activity for specific types of pain and relieve concurrent symptoms which exacerbate pain. Antidepressants and anticonvulsants are first-line adjuvant analgesics for the treatment of cancer-related neuropathic pain. These are, we can use glucocorticoids, antidepressants, anesthetics, lidocaine patch. This is very effective like prelocaine, anticonvulsants. Validation, yes, it is valid. Role of what are some reasons for not receiving adequate treatment for pain? Reluctance of doctors to ask about pain or offer treatments. Usually there is a very much of reluctance on the part of doctors to offer pain treatments. Reluctance of patients to mention their pain, fear of addiction, fear of side effects, constipation, nausea, drowsiness. What about 10% of the patients that Dr. Nihal has already talked about? Interventions. Types of alveolar interactions, intervention techniques he has already explained. Now the Seagull sign we see on USG for the celiac plexus. This is our article published in Times of India, Forget Good Life, India Worst in End of Life Care. It's not the cancer, it's the pain that's killing me. This is slide. People may not remember what you say or what you do, but they will always remember how you made them feel. I won't take much of time. Okay, thank you. Thank you.
Thank you, Dr. Anupam. Please take your seat. Now I'd like to invite Dr. Ruma Bhattacharya for her topic on psychotherapy and counseling.
Yeah, good evening everyone. Good evening the chairpersons. Yeah, so it's also said that there is no gain without pain. So I'm sorry you all have to bear with me before you can head for dinner. So please bear with me. I'm going to talk on psychotherapy. Yeah, so cancer, psychotherapy in pain management. So GI cancers pose physical and psychological challenges, we all know that. Psychological interventions are crucial in pain management. Pain originates from the disease, treatment and complications. The nature of pain is also complex. Emotional impact includes fear, anxiety and depression. Psychological factors contribute to pain perception. Anxiety and depression can heighten the pain sensitivity. Negative emotions amplify the pain perception. Impact of pain is seen on psychological well-being. Chronic pain leads to helplessness and loss of control. Emotional distress impairs the coping mechanisms. So we have to understand pain. There are of course medications for pain relief. All the previous doctors have spoken on this. There are also complementary and alternative therapies, and of course for me, the most important are the psychological interventions. What is this? Prize. What do you see in this? Huh? Did we know about branding earlier? Yeah? So branding refers to a process whereby third-degree burns are inflicted on the skin with a hot iron or a metallic object. The phenomena was counter-irritation and is widely used by faith healers in developing countries for therapeutic purposes. Some methods, which are very crude and inhuman, carry a large risk of complications. So, what is the cycle of chronic pain? Pain evokes feelings of anger, anxiety, distress. Negative emotions deprive one of contentment. And lack of contentment can lead to depression. Depression can again lead to higher perception of pain. The more the pain one feels, the less activity one is likely to do. Weaker muscles and joints are also more prone to pain. So it's a whole cycle. So what is the role of psychotherapy in pain management? It addresses both the physical and the psychological aspects. And basically it promotes the coping skills and emotional resilience. So what are the different psychotherapies which are helpful in pain management? Cognitive behavioral therapy, mindfulness-based stress reduction, acceptance and commitment therapy, hypnotherapy. So what is cognitive behavior therapy? It aims to change the negative thoughts and behaviors related to pain, leading to improved coping skills and reduced distress. So we all know when there's chronic pain, it will cause reduced activity and movement, it will cause distressing emotions, there will be avoidance of work or withdrawal from activity, physical distress, and again it's a chronic cycle. So how do we do these therapies? We will assess. The therapist conducts a thorough assessment of the patient's pain experience, identifying maladaptive thoughts, behaviors and beliefs. We need to psychoeducate the client. Patients learn about the biopsychosocial model of pain, understanding the interaction between physical sensations, thoughts, emotions, and behavior. Cognitive restructuring. Patients identify and challenge the negative thoughts and beliefs about pain and replace them with more adaptive and realistic ones. Behavioral activation. Patients engage in pleasant and meaningful activities despite pain, gradually increasing the activity levels to improve the functioning. Relaxation training is important. Patients learn relaxation techniques such as deep breathing, progressive muscle relaxation, guided imagery to manage stress and reduce muscle tension. There is also this mindfulness-based stress reduction. So it teaches mindfulness meditation, body scanning, gentle yoga to cultivate non-judgmental awareness of present moment experiences, including pain. So both mindfulness-based cognitive therapy and mindfulness-based stress reduction is about mindful awareness. It is the foundation of both the programs. Paying attention to the experience, thoughts, emotions, and the body are significant and are central to mindfulness skills. In cognitive therapy, it helps in preventing depressive relapse, treats depression and anxiety, enhances awareness of negative states, builds self-care, uses mindfulness and CBT exercises to shift the unhelpful attitudes. It explores patterns of thinking, emotion, and behavior, emphasizes choice in responding to distress, and develops skill, what to do when low mood and anxiety arises. In mindfulness-based stress reduction for the general population, acute or chronic stress, examine the effects of chronic stress, again use the mindfulness to teach healthy responses. Mindfulness meditation is very important. Patients practice mindfulness techniques to observe and accept pain sensation without reacting or judging. Body scan, patients systematically scan their bodies, paying attention to physical sensations and emotions associated with pain. Yoga is of course helpful in gentle yoga poses and movements, focusing on breath awareness and body alignment to promote relaxation and flexibility. Group therapy is again very, very important. When you people treat patients with cancer, please put them in groups and talk about pain, ask them about pain, and also teach some mindfulness-based therapies. Acceptance and commitment therapy. It aims to reduce to increase psychological flexibility by promoting acceptance of pain and commitment to value-driven actions. So I think because the time is short and we all are waiting for dinner, I'll not go into the details of acceptance and commitment therapy. Hypnotherapy is also very useful. So there are so many therapies. We have to know that how the pain event, we have to break this cycle, break the pain cycle, control the fear, because a lot of patients with pain are fearful, anxious, depressed, insomniac. So break the pain cycle, control the fear, focus, direct away from the pain, reduce the stress, renewed sense of control and hope, and better quality of life. As doctors, it is all about providing a better quality of life to the patient, treat the patient as a whole. Holistic treatment is very, very important, not just medication and not just surgeries, but we have to treat the patient as a whole. That is all I want to say. There are a lot many therapies, but we have to treat the patient and treat the pain. Thank you so much.
Thank you, Dr. Ruma. Please take your seat. As we are already running short of time, so I will permit a couple of questions. Before that, I would like to make one comment on Nihal's deliberation, that endoscopic treatment of pain has been going on for years together. And rather, I will say that is the initial thing, whatever palliative thing you do for taking care of distended ducts, whether it is pancreatic or biliary tree, that is nothing but, because the biggest reliever for patient point of view after stenting is pain only, because it is the distended duct, whether it is pancreatic or biliary, which causes severe pain in GI malignancies. So this may be a newer approach for celiac block, but as far as the endoscopic intervention goes, it is for years, and it is one of the biggest reliever of pain as far as pain is concerned, because that is what causes relief. Stunting may not prolong life, as we have heard throughout the day. It may be just couple of months, may change here and there, but from patient point of view, great relief of pain may take place, because it is just distension of the ducts which causes severe pain in hepatobiliary as well as in pancreatic duct malignancy. Any questions from audience, please? If there are no questions, we close the session. Thank you very much for giving this opportunity, Dr. Kumar. And it was a wonderful deliberation entire day. We have enjoyed, although we are little delayed, but now we can enjoy dinner as well. Thank you.